All right, thank you for joining us for this month's meeting of our Artificial Intelligence Working Group, the first one of 2026. And so the main item that we wanted to go over for today was a recent request from information that was issued from Health and Human Services about the use of AI in clinical care. And so I wanted to go through some of the specific points, see what our thoughts were as a working group on this, and how CTeL might want to respond to some of these points. But before we get into that, I did want to make note of the recent HHS funding bill that included a handful of other agencies that was released earlier this week by congressional leaders. The bill, if passed as is, would provide for an extension of Medicare telehealth flexibilities through the end of 2027. Um, and specifically for purposes of the AI working group, I also wanted to make note of something that we found kind of interesting about this, that in the 1,059 pages of the bill, a bill that includes the funding for the Department of Defense, Homeland Security, and other big agencies, the phrase artificial intelligence is only used once in the entire bill. Um, and so, given that and the way in which these bills have been very negotiated and bipartisan, there doesn't seem to be a whole lot of controversial policy riders. We were just talking about this a little earlier. In these bills, and based off of the momentum of previous funding bills that have passed with overwhelming bipartisan support, there is a good likelihood that by the end of this week, the House will have passed all bills to fund the government for the rest of the fiscal year, and that the Senate will take them up next week when they're back in session. Of course, the current continuing resolution funding the government expires on January 30th alongside telehealth flexibilities. But however, if things continue going at their current rate, there is not likely to be another government shutdown. Any questions on that before we get into some of the specifics on this RFI? And of course, oh, Chet.
No, I'm good. I was going to tell you. Please proceed. Thank you.
Yep. And if you have any questions or would like to set up some time to chat, I'm always available. So last month, right before the end of the year, HHS, specifically the Assistant Secretary for Technology Policy, Office of the National Coordinator, put out a pretty big request for information titled Accelerating the Adoption and Use of Artificial Intelligence as Part of Clinical Care. This was published on December 23rd with comments due in February, late February. And the commentary that HHS provided in publishing this RFI is that it is, quote, seeking broad public comment on what HHS can do to accelerate the adoption and use of AI as part of clinical care. And so this isn't a particularly new stance for HHS or the administration to be taking. Um, as I'm sure we all know, the administration has been focusing very heavily on ways that it can promote um, the development and adoption of artificial intelligence tools, not just in healthcare, but across every industry in the US. And so there's a number of specific questions that HHS included in this that CTeL is working on putting together comments for. And so for today's working group meeting, I wanted to kind of go through some of these, see if we had any thoughts that we can incorporate into a collective letter from CTeL. Any questions on the basics of this request for information? I'll also put a link in the chat so you all have that for your own reference as well. And so the first question is pretty broad. And HHS is asking, what are the biggest barriers to private sector innovation in AI for healthcare and its adoption and use in clinical care? Do we have any thoughts on this question?
I would imagine the privacy of patient data is a concern that I would have for my own records, but uh, uh, ensuring that there are no hallucinations in any AI usage would be the second concern. And not necessarily there are barriers, but certainly those are the patient side views of use of AI in healthcare.
Yeah, kind of like patient perceptions on accuracy, um, as well as issues surrounding data privacy and ownership.
Right.
Some of the other points that we've been kind of thinking of as we approach this question include the technological infrastructure, um, especially for smaller clinics and health systems. Um, has anyone had any experience where the technological infrastructure at your practice has been a barrier to adoption and use?
I I had my internist retire on me, so I had to now go see a different doctor. Same practice, but they had changed their systems. So uh, all my prescriptions and uh, prior interactions with the pharmacy were forgotten by the old system now. And I was thinking that if there was an AI in non-clinical applications by which such transitions can be managed easier, or for that matter, actually advancement of prescriptions by the doctor that is entered into the record, in an electronic healthcare record, can, under use of agentic AI, can be advanced to the pharmacy so that buttons don't need to be pushed by anybody. And as soon as the doctor has prescribed these medications or procedures, it can be automatically be advanced to the appropriate pharmacy or lab or whatever. That might be making things a little easier. Anyway, this is recollections from my day yesterday, so sorry about that.
Yeah, I think transitions in care, this is something at my previous job before I joined CTeL, I did a lot of work on. Um, and especially in a virtual care environment where patients may experience kind of going between different doctors and clinicians over the course of their care. Um, I think that's a good point to emphasize and kind of ties into some of the other challenges facing digital health practice and implementation generally.
Yeah, I think the use of agentic AI is safer in health as opposed to generative AI. And what I like about thinking about applying agentic AI, especially in telehealth, is actual coordination of the patient's time, doctor's time, and the technical resources under which such care can be scheduled and measured to have actually been delivered and then taking it all the way through into billing, I think would be something that agentic AI can do without really a huge fear of hallucinations that is prevalent with the generative AI. Yes.
This is Iris, and I agree with that, Chet, but I also think what we keep forgetting and what some of the feedback was from the preliminary tries of agentic AI with our institutions. Well, I mean, we haven't abandoned it, we're going back to it, but, and part of it was our transitions to Epic, but before that, the consumer feedback was that they did not like the agentic AI. So I think
Mm,
whatever we
mm,
do, we have to include the
yeah.
end user in it, right? Which is not just the providers, but also our consumers.
Spot on, Iris. Right on. My I mean, I would not want the agentic AI to start badgering me or bothering me. Um, but background functions could be a lot easier, could be handled without,
Oh, for
it's
sure. For sure.
significant labor savings is what I'm thinking.
And I think that's a really important thing that I think Krista had talked about a while ago in terms of allowing people to work to the top of their license. I think there's a lot to be done in that space
Hmm.
by, by organizing the agentic work and separating it from the clinical. And I think it's hard to do in a way, but it's different work than the clinical diagnostic pieces of
Yes,
it.
right, right, right.
Iris, this is Joe. I came in late, but what was it about the agentic AI that people disliked?
I only got the feedback that they did not like it, that they felt it didn't have that personalized touch or the ability to ask questions or clarify. And it could have been the model itself that we piloted, which was quite a while ago, to be honest. I know we're revisiting it. I know it's not out of the picture. Um, I don't have much more than that, Joe.
Thanks.
Hmm.
The the agentic AI that I was thinking about um, is more of think of it as a gremlin working for you inside the big box. Um, AWS calls it service as software. So it does all these different things, um, and not generating things, but it is just uh, executing procedures that or processes, business processes that it might have taken a human being to do. So uh, having that kind of a process support is my idea of agentic AI as opposed to having it interact with clients. And I would not want to be bothered by or badgered by an AI just because it doesn't like my answer. It keeps coming back at me. That would annoy me. Yeah.
Mm.
So.
And another barrier that we've heard from some members before is workforce readiness. Um, has anyone here had any experience with that being a barrier to adoption and use of AI?
This is Joe. Lydia, I don't, but I did see in a Wall Street Journal from, was it, was it 2 days ago? Or maybe yesterday, I forget. Workers who are making money training AI to replace themselves.
Mm.
And they recognize that it's rather a short-term gig, but they're taking what they can get.
So I have a question because AI in radiology has been around for a while. Are there lessons learned that we can take from that world? And not being in radiology, I don't really know what the barriers were or still are. I guess that's
Micah?
no.
I don't have an answer to the radiology question. But
Specifically with respect to the workforce?
well, with respect to workforce, I'll just give an example that so our medical association had a meeting on AI use in clinical care. And so it was a big symposium, and they asked people from all over the state to show up. And we had developers and leaders from Microsoft who were working on their model and everything. And the clinicians were giving examples of how they use AI. And the thing that became very clear to me is the understanding of what is using AI versus what is actually integrating it into your clinical work. And so most clinicians that were presenting and talking were talking about, oh, I use open evidence or I use these other things to either generate some sort of a policy document or research what is out there. But that's not being directly used on the patient, right? That's informing them. And I think there's a need to be clear on the definition of what is AI use in clinical care. So for my money, that definition is you have an actual agent or AI tool that is directly interacting with the patient, whether it's dealing with monitoring or whether it's some sort of a chat intake scenario or whether it's clinical decision making support. Those in my definition, that's using it in clinical care. The definition that these clinicians were using, to me, that's essentially the same thing as using up to date. It maybe is more reactive and provides easier things for you. Especially the prime example was generating basically a clinical standards document and then having the sources to cite all developed in there. So I think that's been a bit of a confusion. I don't know if it's a barrier at this point because, like I said, a lot of clinicians think that they're using AI when they say that, and technically they are, but they're not using it with patients.
Mhm.
If I may go back to Iris's point about radiology, um, in a larger sense, obviously, use of AI in diagnostics, whether it's a breast cancer diagnosis or a prostate cancer or whatever, the interpretation of the images, um, if the LLM, which has stored all these images and the AI has gotten smart on the LLMs, uh, if there are very few such, uh, if the data lake is small, then you are not going to have a high level of accuracy. So my recommendation might be to the HHS to actually create a public sector LLM for all kinds of images that have been collected already and centralize them so that individual healthcare practices or providers can then point their patient's X-ray image to put it through that public LLM so that you now have a huge data lake, maybe an ocean, through which you have a far better chance of a cleaner, better, faster, more accurate diagnosis. So, in a nutshell, expansion of the LLM on which the AI is making its recommendation and to centralize it under HHS could be a great public service.
And I think that brings us to the second question pretty well. In what regulatory payment policy or programmatic design changes should HHS prioritize to incentivize the effective use of AI in clinical care and why, including regulations, policies, or programs that could be revisited to augment the ability to develop or use AI in clinical care? So it sounds like prioritizing data collection for use of better training. Any thoughts on that or any other ideas for regulatory payment or programmatic design changes?
I guess my head goes back to consumer protection, and if we're going to create something like that large lake that Chet is talking about, a consent process or an inclusive, or it's more of an opt-out rather than an opt-in. Does that have to be within any of the covered programs that you might use? Because that's massive to create that amount of data. That's something that's been dealt with on state level as well as national. So I don't know where we stand on that.
Iris, from a consent standpoint, are you thinking mainly of privacy concerns?
Yes. It's,
Yeah.
it's your health data has to be put into this pool. And I think if it's de-identified and we have a process for clearly de-identifying it, that alleviates fear for most people. But I don't know that you can, I don't know if there's a universal way to admit all that data in order to teach the models and have highly reliable models that aren't biased.
Mhm.
Yeah, I agree with that.
Well, the bias problem might not be the thorniest, because if we did it at a scale of the type Chet has in mind, that would encompass such a broad swath of society that I should think if anything is going to be representative of the patient population in America, it would be something of the type that Chet alluded to.
Yeah, the bumps would flatten out at that point. Yeah, right.
Yeah. Now the privacy is more difficult, but it ought to be technologically possible to do this in a fashion that would make it very difficult to identify which patient goes with which image.
Actually, Joe, not just the image, but also the diagnosis that was
Right.
made
Good
as of
point.
that. Yeah, right. So it's a connection that should
Exactly.
go
Yep.
with the image. Yeah, right.
Yep.
Mhm.
Exactly.
Yeah. Lydia, I have one other point
But
on
you do
on
have to
this.
keep the
Yeah,
diagnoses there in order for the data to be adequate for training. I mean,
yeah, exactly. Right, 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 right. Uh, Lydia, and I'll shut up after this. The point, the the value we as promoters of telehealth ought to push for in this sort of a invitation for innovation that we are asking for. I think it would be great if we could uh, suggest mechanisms by which we can analyze the experience we have collected so far the last 5, 10 years, especially 5, 6 since COVID, on the way we administer telehealth and what can we do. And I'm not looking for generative AI suggestions, but potentially implementation of tools like the agentic AI, et cetera, to assist in the delivery of the telehealth, make it less costly, make it more efficient, make it more personal. If the analytics of the telehealth administration over the last 5 years can be collected and analyzed to improve this process, I think us championing something like that could be useful, especially to these rural caregivers who are under such tremendous cost pressure.
I think that's a good point. Any other thoughts on number two?
I'm going to betray some ignorance here. I don't have a good handle on the extent to which residents in the different specialties are being trained in the use of AI in their disciplines. But since the government, through its reimbursement programs, funds a great deal of the postgraduate education in the country, would a programmatic modification be appropriate to perhaps make financial support in part dependent upon some commitment by the part of the teaching hospitals that some portion of each resident's training will be designed to enable him at completion of his training to be able to use the technology effectively and cost effectively. Now, if that's already being done, and I'm ignorant of that question, then maybe that's not necessary, but I just don't know.
Micah?
Sure. Just a couple of things on that, Joe. So the first is, and I realize that the plural of anecdote is not data, but the anecdotal conversations that I've had with a lot of folks who are in the training roles here, they don't let medical students and residents use AI, simply because they don't know what they don't know in some cases, and they won't realize if it's hallucinating and giving them bad data. So there's pretty much a informal blanket prohibition on that. The second thing is, I think you're right. HHS certainly could, in the form of CMS, attach residency funding triggers with respect to training requirements, maybe in residency. I would probably find that more acceptable than in med school. The problem that I think we'll run into there is that not every residency is funded by the federal government. In fact, many states use state funding to do that. So those particular positions would not be subject to such a provision. I mean, I think that the states could probably adapt that, and it would be cheaper just to adapt them all. So I would hope that that's what would happen. In our experience here, the majority of the state-funded positions are actually primary care.
I understand the concern. At the same time, I would be pretty well astonished if pretty much any doctor or other clinician, for that matter, in almost any branch of the healing arts, won't in the foreseeable future need to have some understanding of and capacity for intelligently using artificial intelligence, including an understanding of its limitations, which would certainly include the hallucination phenomenon, which, at least according to my reading, seems to be receding to some extent and less of a problem than it was back a couple of years ago. I don't know that that's true, but I've read it.
I would disagree with that, Joe. Mostly because of your colleagues in the legal field. We actually just had a hallucination case for a Tri-Cities disability lawyer who claimed that they contracted out with someone for a filing, and it was all hallucination. None of the sites existed. And so it went up basically they had a show cause hearing, and they forced the person to make a filing of why did they do that. They said it was, again, a contractor, but the end result is they kind of did a scarlet letter version on this individual. So they were removed, as I believe they said, post hoc counsel from that case because it was in New Mexico and she's in Washington. And then for the three-judge panel that they dealt with before, she has to write a letter explaining that she did that and what action has been taken. And from every case that from now until eternity, that she's the eternity of record, she has to provide the show cause order and be clear about the fact that she was sanctioned. No word on whether the Washington State Bar is going to take any further action.
I am aware of this phenomenon, which I frankly find astonishing, that lawyers have filed pleadings citing to non-existent cases, imaginary regulations, and so forth. That takes more chutzpah than I aspire to acquire. You're signing your name as an officer of the court. On the other hand, to quote from my learned friend Micah, the plural of anecdote is not data. What I have read, and it was purely medical, it was not legal for this particular purpose, is that hallucinations remain a problem, but that the prevalence of the problem seems to be diminishing, and that there's therefore optimism that with time, this will become less of an obstacle than it currently is. But I guess my point was that either way, the professionals of the future need to have a grasp of the technology, its capabilities, its limitations, its benefits and disadvantages, and so on. And residency, arguably not medical school, but arguably the other way, would be a logical place to provide that instruction. And it's certainly true that postgraduate education has various funding sources, but it's still my impression that the fraction that the federal government pays for, meaning you and me, is high, and CMS has a lot of clout with GME generally for that reason.
Sure.
So, not a perfect answer, but maybe a step in the right direction if it isn't already being done, and it sounds as though it's not.
No, I think it's pretty much come to the various individual medical schools and programs about what they're doing. I can just speak to what I know is occurring in Washington State. Joe, a question that I have for you is, maybe focusing on residency is sort of too late. And I wonder, does it hold any value to maybe push at least the education and understanding of AI to a much lower grade level? I could see a scenario where it's a junior high school thing where, because I mean, you don't just want the physicians and the other practitioners to be aware of how AI works. There's a patient component that is desperately needed as far as understanding as well. And so I'm just wondering if there's a consideration of doing that.
That's an interesting idea, and it might make a lot of sense. I'm not sure that the question, which is geared towards HHS, is I'm not sure HHS is in a position to promote that concept. Maybe it is. There might be other agencies better suited to it, but I certainly think you're right that, I mean, kids get out of high school with no grasp of how to use the emergency department, never mind what we should and should not use AI for in healthcare.
Right.
This is a lay view. I like the idea of starting off the AI exposure, both risks and rewards, much lower level than residency. I think when people begin to understand what AI can do, they can really come across some new ideas with which to reimagine the practice itself. So I think that starting them off at a lower level, Micah, your point is a very good point. I like it.
Well, given what's happening on the federal level to the Department of Education, I have no idea who would be responsible for trying to put that book.
Well, and from what I read, high school kids, college kids, even younger, are using AI for purposes that we might not necessarily encourage already, such as doing the term paper by machine instead of by yourself. But maybe we should just acknowledge that that's a reality and reverse the negative consequences by taking the bull by the horns and just making it part of their educations. My point about residency was simply it's great to have some general background in the field. I wish I had a better one than I do. The question is, how do we use it in dermatology specifically? Or I don't know, pediatric psychiatry, or whatever is your world, your field.
So it looks like we've got a little less than 10 minutes left, and so I wanted to go over one more question that might be relevant to folks who are here. And that's number three, which is looking at for non-medical devices. Um, we understand that the use of AI in clinical care may raise novel legal and implementation issues that challenge existing governance and accountability structures relating to liability, indemnification, privacy, and security. And so HHS is asking what novel legal and implementation issues exist, and what role, if any, should HHS play to address them?
I would say from the regulatory side of things, what we are seeing with use of AI in medical practice is just a complete ignorance, again, of how it works. And when you are exposing HIPAA covered information to the model and understanding that that instantly generates a HIPAA violation because it's going to a privately owned server, and it becomes part of the training model generally. So, I mean, I think we've got no less than 6 cases of clinicians feeding in patient data into Chat GPT and then saying create an after visit note. And some of those are complicated by the fact that there's hallucinations in there. Some of them are complicated with the fact that the clinician was in a rush and they sent the wrong after visit note to the wrong patient.
Mm.
But it's absolutely happening. We're at the point where we're probably going to have to send out a regulatory announcement saying, for the love of God, stop using Chat GPT to do your patient visit notes. That's a HIPAA violation. Please stop, just for our own sake.
Lydia, I think use of continuing education under the AMA leadership or any other credible uh, organization that can provide continuing education on the use of AI and essentially HHS saying a doctor or a nurse can't use AI unless they have done that course and passed it or some level of competence in understanding the use of AI might be a way uh, to initiate this discussion.
That's a good point to raise as well. Any other initial thoughts on some of the novel legal and implementation issues?
Lydia, I suspect some of those may well require legislation. And I don't know that an agency such as HHS, well, I don't know how comfortable they would feel trying to influence the Hill or for that matter, um, other legislatures. But uh, HIPAA was arguably out of date when it was passed. It's certainly not on top of the current situation, but HHS can't do but so much about that. Same is true, I suspect, with the equivalent or at least the analogous legislation at the state level. When those statutes were enacted, nobody dreamed up the current situation. Nobody really thought AI just wasn't on the horizon.
Yeah, when CTeL had our meeting with the HHS Secretary's office this past summer, they did indicate that they were considering some updates to HIPAA regulations. And so this is something that very well may be coming in the pipeline from HHS as well. Um, so we'll see if there's a good chance that'll probably address AI in those regulations as well.
Hmm.
Any other thoughts before we wrap up the meeting for today? I did also want to make sure if there were any items we didn't address today. Um, I did want to highlight one other story that came up recently coming out of Utah. Um, some of you may have already heard um, that Utah has launched a pilot program to allow a AI tool to issue prescription refills for patients in the state and are creating a special regulatory sandbox for that to kind of study its
Hmm.
effects and implementation. I put a link to the state government's press release on the matter. Um, and so this is the first state and program in the country to do so. This is something that about a year ago, uh, this month, CTeL sent a letter to members of Congress who are proposing a bill to do the similar thing at a national level, um, cautioning against such an action. And so we will continue to see how Utah moves forward on this issue. But that's just another story I wanted to highlight for you all as well.
Lydia, in the Utah proposal is human in the loop. That is does the AI purport to make the judgment that renewal of the script is needed and appropriate? Or does it propose yay or nay, and then some prescriber, presumably, some prescriber then say, yes, I agree, or no, I don't?
Joe, my understanding is there is no human in the loop, but there is a restriction on what it can do. It's renewals only.
Mhm.
I believe they do limit the controlled numbers, so I don't think there's any C2s allowed. Uh,
Ah,
and then I think they also limit, Lydia, correct me if I'm wrong, I'm trying to remember, mental health uh, medicines, like the lithiums of the world and that sort of thing.
Mm.
yeah, thank you.
I can't remember the class of drugs those are, but
Yeah, it's pretty limited in terms of the scope as well as what specific medications are actually eligible for it.
Like, say, Tylenol during pregnancy. Never mind, I withdraw that.
I don't know whether such a thing would take a look at any blood tests or any other such measurements to enable the renewal of the script. I don't know. This is curious. I'll have to read this.
Yeah, I'm not clear if the AI has the ability to look at the EMR. I have my concerns with that simply because if anybody that has gone into their doctor and used the EMR, the med reconciliation list is almost always wrong.
Mm,
And so if it's, I mean, the AI doesn't know to question that. So I think that's probably going to result more likely in some denied renewals that were inappropriately denied. And so I'm going to be curious to see how they address that.
Hmm, interesting.
So with that, we are right at time for today's meeting. Thank you so much for joining for the discussion and for helping shape our response to this RFI. I did want to note that we have a webinar coming up next week talking about some of the insights from our newest 50-state legal survey that we're putting out that has been distributed for a pre-publication review. Um, Next week, we'll be talking about some of the insights. This one includes some research on the state legal landscape of the use of AI in clinical care. And so there's a QR code on the screen for that, and I'll also drop a link in the chat as well if you haven't registered already. And with that, that's all that we have for today. Thank you so much for joining for this month's meeting. Our RPM working group meets next Monday at 2. And if you have any questions or would like to set up some time to meet, feel free to reach out at any time. Thank you so much.